A very good morning to the respected participants from Pakistan and a very warm welcome and afternoon to the folks from Darwin, Australia. It is my absolute honor and privilege to host the webinar of such prestige from the platform of Iqra University, Karachi, Pakistan, in collaboration with innovative research universities. My name is Javaria Shaikh and I'm serving as a lecturer economics, business administration faculty at Iqra University, Karachi, Pakistan. Iqra University traces its genesis to January 1998 when it started its operation in Karachi, Pakistan. Iqra University is determined to achieve its mission of being a world-class institution of higher education and research, promoting technical skills, critical thinking, and public duty to help develop a prosperous and progressive society. The university in this area offers graduate and undergraduate. So the university is basically in this regard offering graduate and undergraduate and continuing education programs in all disciplines, including education, English, computer science, business administration, international relations, development studies, fashion design, and textile design. The programs in these disciplines are conducted under the supervision of a highly qualified professional and motivated faculty. The university curricula are not only competitive, but also in line with academic practices globally. Iqra University is proud to be collaborating with Innovative Research University. IRU is a coalition of 7 comprehensive universities, Australian universities, which are committed to inclusive excellence in teaching, learning, and research in Australia. The member universities include Charles Darwin University, Flinders University, Griffith University, James Cook University, La Trobe University, Madrouche University, and Western Sydney University. The members' commitment and impact is both local and global with a focus on advancing communities through education, resource, opportunities, and enterprise. The IRU's members' research focus is on the translation and the commercialization of research on issues of critical importance to the communities in which they are based in addressing problems of national and global scale. As an outward-looking network, the IRU seeks to strengthen Australia's integration with the countries of Asia, such as Pakistan. Today's webinar, Reshaping the Post-COVID World, Health, Inequality, and Tourism, is one of the links. I am humbled to welcome Ms. Sabi Qayyum, In-Country Manager, Pakistan, IRU. Thank you, Ms., for your efforts in organizing today's session with one of the member universities of IRU. I would like to take this opportunity to thank Mr. Greesh, the Regional Marketing Manager, Charles Darwin University, Australia, for being the link in this webinar. Along with that, I would like to welcome the respected panelist, Dr. Maneka Jayasinghe, who is a senior lecturer in economics in the Asia Pacific College of Business. And Dr. Maneka is a senior lecturer in economics in the Asia Pacific College of Business in Lord Charles Darwin University. She's an applied economist with research interest in consumer demand analysis, poverty, inequality, and well-being, feminist economist, and tourism analysis. Her research has appeared in international retreat journals. She holds a PhD in economics from Griffith University, Australia, Masters in Public Policy from National University of Singapore, and Bachelor of Economics from University of Colombo, Sri Lanka. Thank you, Dr. Maneka, for joining us today. I would also like to welcome Dr. Bhanu, who is a non-stream economist. Traditionally, mainstream economists have assumed people to be rational individuals motivated by self-interest. Sociologists have long criticized the abstraction of economic models from culture, historical, emotional, and interpersonal aspects of commercial exchange, but often ignoring the role of human agency in actions. Using the framework of economic sociology, Dr. Bhatia's work considers the embeddedness of economic action in the broader social space, combining rational choices, theory, and relational dimensions of choices. Pushing boundaries by experimenting with new methods is extremely important for her, and that is her forte. Dr. Bhanu's education in background includes Bachelor's of Economics from Adelaide University and PhD from Macquarie University. Thank you for joining us, Dr. Bhanu, today. And Dr. Debajyoti. He is a lecturer in College of Business and Law, specializing in economics and finance. He has taught a wide range of courses in economics, finance, and statistics. Before joining the Charles Darwin University, he was basically serving as a lecturer at Australian National University and Sydney University. Dr. Debajyoti completed his MA and PhD in economics from Rutgers University. His research has been published in journals of international repute. He has been awarded the Sidney Simon Teaching Prize in Economics from Rutgers University. Thank you, Dr. Maneka, Dr. Bhanu, and Dr. Debajyoti for joining us today as a panelist for the discussion. Today's topic, Reshaping the Post-COVID World, Health, Inequality, and Tourism, holds a great relevance to the international context, as after COVID-19, there is a risk that the world would be yet more divided, conflictual, and nationalistic. But an alternative scenario is within the reach. In this scenario, collective action within communities and, where necessary, internationally, will make a more rapid and peaceful exit from the crisis. While a global pandemic has been a looming risk for decades, COVID 19 has become a shock to the society. Health systems, economics, and governance worldwide are suffering. In the midst of extraordinary challenges and uncertainty and countless personal tragedies, leaders are under pressure to make decisions on managing the immediate impact of the pandemic and its consequences, decisions that will shape the state of the world for years to come. What might be the silver lining in the crisis, and how might leaders use this moment to build a more prosperous, equitable, and sustainable world remains a challenge. Economic reconstruction is one of the most important challenges in today's time. After the Second World War, war-torn countries were desperate to get their economies restarted, debts had to be withdrawn, new flows of investment had to be found. The result was a massive reset, delivering massive housing, health, employment, tourism, and education. But this might not be the possible case in 2021. Some challenges occurring during the crisis could be built upon. It is difficult to imagine that the traumatic experiences of the pandemic will be forgotten quickly or disappear entirely over the time. The human losses alone will remain stronger reminders of the implication of change at the level of society and individuals. The new start after lockdown will certainly offer opportunities and carry risk for all. In this context, how can we reduce the growing inequalities, the widening gap between privileged and underprivileged segments of the society? And how can we make the basic amenities of life, such as health and education, more inclusive and sustainable? And how can we reconstruct the economy? How can we ensure the safe tourism remains a primary challenge? With this thought, I would like to invite the respected panelists to please start with a discussion on the topic. We would limit the discussion to about 40 to 45 minutes, followed by a question and answer session. That would be for about 10 minutes. You, the participants, basically can send the questions through the chat, Zoom chat option. And I would be choosing the questions that would be more relevant, and I would be forwarding it to the respected panelist for to answer. Thank you so very much. Over to you. Dr. Maneka, would you like to start? Yeah. Thank you. Dr. Maneka, you're not audible. Perfect.
Great. All right. Thank you for the introduction, Javaria, and welcome everyone. We're really happy to connect in this way, something that probably wouldn't be possible in the pre-COVID world. So that's a good outcome. um, so today we will be presenting on reshaping the post-COVID world, health, inequality, and tourism. This work is really the brainchild of Debajyoti, Dr. Debajyoti, and Dr. Maneka, who've been like rest of us watching the news and have watched the suffering that's going around the world right now and wanted to do something about it. So we decided to bring our common interests together, which is on inequality, and look at this aspect of COVID. And while we were doing that, we realized how important globalization was also in the puzzle. And therefore, we've also extended this work to look at tourism and regional tourism as well as international tourism. So it's part of a bigger research agenda that we've started working on, and we're really excited to share this work. Sorry, my screen's just frozen on me. So, okay. Before we begin, we are connecting with you all from Darwin, as Javaria mentioned, in Australia. It is very hot here, but the aircon in our building is really cold. Hence, we're all wearing jumpers and so on. Look, as you all know, Australia is one of the oldest civilizations, and for centuries have been managed by Aboriginal and Torres Strait Islander people. Charles Darwin University acknowledges the traditional custodians of the land on which we are meeting and pays respect to elders both past and present, and extends that respect to all Aboriginal and Torres Strait Islander people. I'm going to be kicking off with the discussion of socio-economic inequality and the COVID-19 pandemic. So to begin, I'd like to share a little diagram. So health is a basic necessity in life. Health inequality is not only an infringement of human right, but the avoidable mortality and morbidity also impedes productivity. And economists have long realized the relationship between health and productivity. One of the historically popular work on this is by Preston. And so I'm kicking off with sharing the Preston Curve with you all, which simply plots income and life expectancy. So what we see is through this graph is that poorer nation gains substantial increases in life expectancy for small increases in income. But this effect flattens for richer nations. While this curve really discusses the relationship between income and health, so GDP per capita and health, it also implies something about inequality. So one way to think about this question is, suppose we redistribute income from richer nations to poorer nations, we are going to have big increases in health. So more equal society will give us healthier individuals as well. So this was in 1970s. Since then, a significant research effort has gone into studying health and inequality. And some of the pathways through which health and inequality are related is first, very straightforward, is socioeconomic status has been found to have direct impact on health due to its relation with access to resources. And education has been found to be one of the most important predictors in that. Also, inequalities arise due to differences in health behaviors, where higher SES people are more likely to not to live very healthy lifestyles, and they are not likely to smoke, drink, or be obese, and so on. So this kind of has an indirect impact on some of those mortality and morbidity indicators. But all this says is that individual income education is an important factor of health, right? It does not say anything about relative inequality. So going back to that issue of relative income, basically, that can be understood by understanding that relation between individual health and income is concave, such that each additional dollar of income raises individual health by a decreasing amount. So therefore, if we redistribute income from rich to the poor, the average health is going to go up. Hence, again, the same conclusion that equal societies are healthier. Another dimension has been sort of the psychological effects people have living in equal versus unequal societies. So there is a large literature that documents the adverse effect of inequality on health. I've already spoken a bit about life expectancy. This has been examined in great detail across different contexts, different points of time. And while the pattern is not always consistent, there is a strong relationship observed between life expectancy and inequality. Same holds for behaviors such as smoking, drinking. So, if you look at the mortality and morbidity indicators, inequality has a relationship, and also health behaviors. Infectious disease literature, which I think is more relevant to the COVID side of things, also provides ready comparison point for our contemporary times, and with a strong historical counterpart in the Spanish flu. Both confirm the critical roles of socioeconomic realities in incidences of getting SARS or Spanish flu. Studies show while influence cities of Toronto and Hong Kong formed the focal points of the SARS pandemic, possibly capturing the susceptibility of higher income nations due to greater travel and socioeconomic interlinkages, economic modeling analysis of SARS showed that a negative correlation between median income and infection rate in Hong Kong and other places was associated with less affluent groups. So similar.
Sorry for the interruption. You may continue.
No, that's okay. Similar patterns are being observed for COVID. So while COVID appeared to have spread along more affluent and urbanized parts of the world, traveling through various trade routes, as richer places brought the disease under control, the disease is spreading to poorer places. Socioeconomic inequalities in the spread of disease are appearing both within and between countries. So for example, marginalized groups in the United States are more likely to show greater morbidity and mortality. Chicago has a 30% Black population, but more than 50% of patients diagnosed with COVID-19 cases and nearly 70% of COVID-19 deaths involve Black individuals. Social distancing measures, hygiene, quarantine measures are more difficult to be observed amongst homeless people in dense neighborhoods, people relying on public transport, low-skilled workers, and the option of exercising, working from home is just not available for people in lower socioeconomic groups. So this is the aspect that we're really, really interested, or we started off our research in this area, and it's grown since then. And Debajyoti is now going to share some of our results pertaining to this aspect first.
Thank you, Bhanu. Thank you, Javaria, again for giving us the opportunity to share our research with you guys. I will try to share my screen and just check if you guys are able to see it. Is this visible to you all? Okay, that's great. So as my colleague, Dr. Bhatia was mentioning, there is a large literature that looks into the link between inequality and health outcomes. We were naturally interested in seeing when the COVID cases started out, if this was also playing a role in the spread of COVID-19 cases. Now, inequality can be measured in many ways. One of the common ways in which economists and social scientists measure inequality is by calculating something called the Gini coefficient. Gini coefficient is a number that takes value between 0 and 1. If you have a society where income is very equally distributed, you will have the Gini coefficient close to 0. And if the income is very unequally distributed, if most of the wealth or the income is concentrated in the hands of few people, then it will be very close to 1. So we started off by looking at the number of new cases observed across the different countries in the world, and started checking whether there is a sort of a pattern. And I'm sharing a graph, a scatter diagram, which plots the relationship between the log of new cases in the month of April 2020, and in the vertical axis, and on the horizontal axis, we have the Gini coefficient of disposable income across the 165 or 170 countries that were reporting positive cases of COVID at that time. And we thought, okay, this is interesting, but not that surprising, because as what Bhanu has already mentioned, there are many channels through which inequality plays into the spread of infectious diseases. But then the governments across the world started stepping in and introducing measures to try to stop the spread of the COVID-19 cases. So we sort of came back and revisited this question again towards the end of last year. So we looked at the number of new cases between May and November of 2020. And although the diagram here is probably maybe suggesting a weakening of relationship, but if you measure the correlation between the Gini coefficient and the number of new cases, it has actually gone up between May and November. So that sort of gave us a sort of a starting point that maybe it's worth investigating how, if inequality is a significant factor in explaining the spread and the incidence of COVID-19 cases, and whether it is playing an important role in the mortality rates due to COVID as well. So for our analysis, we took data on the COVID cases reported across the world from 23rd February 2020 to 12th April 2021. And we were interested in basically two variables, that is the number of cases, and of course different countries have different sizes, so it's appropriate to normalize, use some sort of normalization. So we looked at the number of cases per million of the population, and we also were interested in the case fatality ratios, which is the number of people dying due to COVID, which we measured by looking at the number of deaths divided by the number of people who have recovered or dead due to the disease. And our source of the COVID-19 case numbers was the Johns Hopkins University database, which I'm sure now everyone is kind of very familiar with, whoever is interested in the COVID incidents. And we wanted to investigate what are the variables that can explain the variation in the COVID cases over time from last year in February till April this year. And of course, there are some variables that don't change over time, like a country's, the per capita income of the country, which is like a starting point. But we are, of course, in order to understand the spread of COVID, we also needed some variables which had some time variation. So for time variation, or to capture the variation in over time in countries as a result of the spread of COVID, we looked at, we used the Google mobility data as a way that, as a data source that can explain how the COVID-19 epidemic has evolved as a result of human behavior. So Google basically started publishing the community reports, community mobility reports from February to help the public health officials understand if their policies are having the right kind of impact or not. So they started publishing the percentage change in the number of people visiting, say, retail and recreational places compared to a baseline period, which was the beginning of 5-week period at the beginning of 2020. They started publishing a number of people visiting grocery and pharmacies, and they publish this data daily, and you can get this information by country. And if you're interested in more finer geographical location, you can get it by different cities and different provinces as well for some countries. So to give you an idea why Google mobility data we thought was going to be useful, here in this graph I have plotted the growth in COVID cases in Australia. So the blue colored line is showing us the initial spike in the COVID cases that happened around the month of March, when a lot of infected people suddenly were allowed to enter into the community from a cruise ship. And so we had a big spike. And as a result of that spike of COVID cases in Australia, the governments cracked down in the sense of imposing a strict lockdown. So people were not allowed to go out of their homes unless they had a very specific reason. And so we can see that this orange colored line tells us how much time people were spending at home compared to the baseline period. So for instance, this peak here is showing that the amount of time that people were spending at home as a result of the lockdown went up by about 22% compared to what they were doing in January. And we can start seeing that as a result of this lockdown, the COVID cases came under control. And so Australia started experiencing a decline in the growth of COVID cases. And of course, then we had a gradual easing of the lockdown. So people started going out more. The amount of time spent at home decreased. And then we had the second surge somewhere around July, which happened in the state of Victoria. And again, so there were, again, new lockdowns imposed. And so the Google mobility data shows us how the governments are reacting to the COVID cases, how people are reacting to the outbreaks, and whether the government's policies are successful or not. So we decided to use this as a measure of time variation, a variable that can explain variation of COVID incidence over time. Of course, we were also interested in some other things. So for instance, there was a great debate around when the COVID epidemic started last year, whether countries which are democratic are better at dealing with COVID cases. So we also looked at some other country-specific indicators like index of political freedom, globalization, because it sort of seemed to us that maybe globalization is a reason why COVID-19 spread so fast. We were interested in medical infrastructure, government's response, and some other social sort of factors which may explain the severity of COVID incidence in countries. So we looked at, we took some of these variables in our analysis, and we used a fairly recent econometric sort of a technique which uses basically, which is called dynamic panel data modeling. And we use that to try and glean out the effect of the factors that we were interested in in terms of their ability to explain COVID cases across the world. And one of our main findings was that globalization does play a big role in explaining the severity of COVID-19 cases. And just to sort of highlight that, I have put in a graph that shows the correlation between the number of COVID cases across countries and the degree of globalization of that country. This is the Swiss KOF Institute's Index of Globalization. Again, the number, if the globalization index is close to 1, it means that the country is highly globalized. And so it suggests that globalization did in fact play a big role in at least the initial part of the pandemic. And our results suggest that more globalized countries had a faster incidence of COVID cases. Another interesting thing that we noticed in our statistical analysis was that the richer countries were more susceptible to COVID. A 1% increase in per capita GDP was associated with about a little over 0.25% of an increase in new cases per million. Coming back to our main question that sort of motivated our work initially was inequality, in particular the Gini coefficient, whether that was able to explain the severity of COVID cases. And we found that indeed it does. Depending on which specification of the statistical result we have, in every specification, inequality was significant. It made the COVID-19 breakout worse. A 1 percentage point increase in the Gini coefficient results in the number of new cases to go up by about 2.5% to 3.2%. And given that the pandemic, the number of new cases is highly, it has got a large autocorrelation in the sense that once an outbreak starts, it takes a little time to build up. So this is a significant. The short-run effect is 2.5% to 3.2% increase. But if you look at the long-term effect, the amount of time it takes for that particular outbreak to be brought under control, the impact, the long-run effect is even more significant. In terms of the government's intervention, we found that if the governments imposed lockdown orders, which resulted in time spent at home, that helped in reducing the rate of spread. A 1 percentage point increase in the time spent in residence led to a 5.2% decline in the new cases. And after controlling for some regional specific factors, so we used some dummy variables for East Asia and other parts of the world, we found that in terms of significant differences, East Asia and Pacific were significantly different from the other parts of the world in the sense that the spread rate was slower there, while in Europe and Central Asia, the spread rate was much faster. We were also interested in trying to understand the differences in the case fatality ratio across different countries. We found that the greater the number of COVID cases, the case fatality ratio went up, which suggested that if the number of cases went up too quickly, it overwhelmed the healthcare system, and as a result, the fatality rates went up. Interestingly, we also found that if a larger proportion of the population doesn't have education, which we kind of proxied by a term called human capital inequality, this is basically inequality of education. We found that more inequality of education was associated with higher fatality rates. Better medical infrastructure, like more hospital beds per 1,000 people, more physicians, not surprisingly, lowered the case fatality rates. And countries with a generally older population and population which had the well-known comorbidities like high incidence of cardiovascular deaths, those countries had higher fatality ratios. Now let me talk a little bit about the policy implications of our study. It's quite clear that high inequality is bad. It increases the rate of spread of the pandemic. And if you're a policymaker and you want to understand, what is happening to inequality as the pandemic is being played out, one of the sort of easy measures that you can look at is the unemployment rate. And maybe the unemployment rate along with the participation rate in the labor market would give you a fairly good idea about what is happening to inequality, in real time as you're trying to devise policy. And just to give you an idea, what I have done here is on this graph, I have plotted the unemployment rate in Australia, which is in the blue colored line. And another sort of well-known example used in the pandemic last year, we have the United States, which is this orange colored line. As you can see that when the pandemic started around March last year, the United States response, the government response was not really very clear. The messaging was not very clear. And as a result, we can see that the unemployment rate, which at the beginning of last year was at one of the all-time low ever recorded in the history of the United States, sort of spike up to close to 15% by April. Australia, on the other hand, the government went very early, and when the lockdown started to stop the spread of the disease, the Australian government immediately announced a big increase in the unemployment benefits. They also announced something called the JobKeeper, which is nothing but a wage subsidy. So the Australian government, immediately, just when the lockdowns were announced, basically told the small businesses that if you keep workers on your books, we will be paying you money. So basically, the government was paying small and medium businesses who were losing revenue because of the pandemic to keep the workers on their payrolls so that the link between the employers and the employees could be maintained. And as a result, what we saw was more compliance with the government messaging of the pandemic, and the Australian unemployment rate didn't go up as much and then steadily declined to the pre-pandemic levels by the beginning of April 2021. Now, when you're looking at unemployment rate, if you're seeing that unemployment rate is going up very high, you know that inequality is rising, and it will be more difficult to bring COVID outbreaks under control, because we know that if people are unemployed, then they will not be following the government messaging around it. But on the top of that, if you observe that the participation rate is falling, then it is even more alarming for a country, for a policymaker. And what we found when we looked at the participation rate in the United States and Australia is that while the participation rate declined after the start of the pandemic, it has come back to the original pre-pandemic levels, whereas in the United States, the participation rate declined, pretty similar to what we have seen in Australia, but it has never actually come back to the pre-pandemic level. So it's still below. And that basically means these are people who are not in the workforce anymore, and maybe the system is missing them. And generally, that is a worrying sign for a policymaker and for a society. To summarize, policy implication that is very important from what we can glean from our results is that you need very fast and targeted intervention from the government to take care of the poorer sections of the society, to control the spread, and to keep the fatality rates low. Now, of course, one of the things that we also found in our in the initial analysis was that the initial spread of COVID was highly correlated with the level of globalization. And globalization is, in one sense, another sort of one of the reasons why we are in a globalized world today. What can explain it is the level of international tourism that we have. And so that is something that my co-author, Dr. Jayasinghe, explored in a lot of detail, and I will hand over to her to discuss her findings in regards to the link between tourism and the spread of COVID-19.
So thank you, Debajyoti. So in this part of the presentation, I'm going to talk about international tourism and infectious disease transmission nexus with a special consideration on COVID-19. So at a time when tourism economy has been heavily hit by the coronavirus across the globe, there's no doubt that the relationship between pandemics and travel is an essential element in understanding health security and global change. The existing research on pandemics reveals that travel and tourism play a critical role in epidemiology and disease surveillance. So we have experienced this at a global level during COVID-19. But before COVID-19, there have been several global health-related crises that have caused significant health risks to travelers and notable damage to the global tourism sector. So disease surveillance and tourism are very much linked with each other, as a vicious relationship coexists between travel and disease spread. This is because, on the one hand, we know travel restrictions imposed to contain the spread of the disease create significant damage to travel, tourism, and hospitality industry. And on the other hand, travel and tourism may be a vehicle which helps to spread infectious diseases. In particular, the increasing frequency of travel, both domestic and international, where rapid transport systems opens a clear route for local outbreaks of infectious diseases to become global pandemics. And this is what partly globalization is, as my colleagues discussed earlier. So we were interested in examining three research questions. Whether the countries with higher volume of international tourism associated with a higher number of COVID-19 cases, and how does the human mobility restrictions and other disease control measures affect COVID-19 cases, and to what extent tourism and government COVID-19 responses have impacted on COVID-19 prevalence in high-income countries and low and middle-income countries. So for this purpose, we used cross-country data for 165 countries to examine the link between the volume of tourist arrivals and the spread of COVID-19 pandemic. We model COVID cases as a function of inbound tourism together with a set of explanatory variables. So the variables used for the empirical analysis are, as I said, number of tourist arrivals as the dependent variable. And then we have proportion of, as an independent variable, and proportion of urban population and number of nurses available per 1,000 persons, proportion of the population over 65 years old, per capita GDP, and whether a country affected by swine flu or SARS. And in addition to that, we also use the Stringency Index that takes the government responses into account. So Stringency Index is a composite index that measures the stringency level of the government response to the outbreak of the COVID-19 pandemic. The data for this variable has been sourced from the Oxford COVID-19 Government Response Tracker. So the index consists of 8 individual government response measures, such as school closing, workplace closing, public events cancellations, restrictions on gathering size, public transport closing, stay-at-home requirements, restrictions on internal movements, restriction on international travel, and public information campaign. It also includes a measure of COVID-19 containment and health response index that contains the information on testing policy, contact tracing, face covering, and vaccine policy. The index ranges from 0 to 100, and 100 is the strictest measure. So in this diagram, we have plotted the number of COVID-19 cases against the number of international tourist arrivals from all countries and high income and low and middle income countries. So as you can see, there is a clear, strong, positive linear association between COVID-19 cases and international tourist arrivals. The regression results indicated that a 1% increase in tourist arrivals contributes to about 0.2 to 0.3% more confirmed COVID-19 cases across all countries. In particular, we observed that the impact of international tourist arrivals on COVID-19 cases on the high-income countries is higher than that identified among low to middle-income countries. And then when looking at the relationship between COVID-19 cases and per capita GDP, we observed that there is an inverted U-shaped relationship. That means COVID-19 cases tend to be higher in low-income countries, and after a threshold income level, the number of reported cases starts to decrease. When considering about the relationship between Stringency Index and COVID-19 cases, we found that at a lower level of Stringency Index, the COVID-19 cases tend to increase. And when a country passes a threshold level of government Stringency Index, the reported COVID-19 cases start declining, again demonstrating an inverted U-shaped relationship. So this implies government measures below a particular threshold level were not as effective as high-level government stringency measures in controlling the spread of the virus. At lower level of stringency index, high-income countries reported more COVID-19 cases than low to middle-income countries. And after the threshold level of the stringency index, the rate of reduction of cases in high-income countries is higher than that of the low to middle-income countries. So you can see there are significant differences between how this COVID-19 and the other variables affect in high-income and low to middle-income countries. And then other results reveal that countries with a high level of health facilities and infrastructure reported a higher number of COVID-19 cases. And this could be because such countries have more facilities to undertake mass testing, contact tracing, etc., leading to more identified cases. A higher proportion of over 65 population is linked with an increase in the number of COVID-19 cases reported, and this is what we have seen in most of the countries anyway. And a higher proportion of urban population is also linked with an increase in the number of COVID-19 cases reported. Poor hygiene, inability to physical distancing in urban areas, particularly for the poor, may increase the risk of infectious disease transmission. And quite interestingly, we found that countries previously affected by SARS and swine flu demonstrated a lower COVID-19 cases than the countries which were not previously affected by those pandemic events. This may be due to the fact that the countries affected by SARS and swine flu had systems and procedures in place for early detection, contact tracing, wearing masks, etc. And therefore, these countries were better prepared to handle and manage the COVID-19 pandemic. So, as discussed, the travel and tourism industry is highly susceptible to the various measures implemented by government and health officials to control the spread of disease. This brings about some extraordinary challenges to recover from pandemic induced tourism downturn. Therefore, it is anticipated that the post pandemic recovery of the tourism industry is of critical interest to tourism industry stakeholders across the globe. However, as further confirmed by the empirical analysis of our research, the travel and tourism industry contributes to disease spread to a considerable extent. Therefore, this study calls for better preparedness of the tourism industry for future health crises and highlights the need for early precautionary action by tourism stakeholders at all stages of infectious disease outbreak. For example, positive collaborations among the health and tourism sectors may bring about effective preparedness for future epidemics. In particular, regular hygiene surveillance at hotels and airports, disease screening facilities, swift reporting and isolation of infected persons may help mitigate the magnitude of future disease spread resulting from travel. Based on our empirical results, demographic composition and public health infrastructure with capacity for mass testing and isolation are important aspects with respect to limiting the spread of COVID 19. The experience of COVID 19 highlights the need for policymakers to work towards strengthening health systems and infrastructure to better manage future health crises. Additionally, planning for the health needs of the various segments of the population, such as elderly, is also an important part of the preparedness package for the future pandemics. And finally, urbanization has long been identified as an issue related to environment and climate change and other human development aspects. However, in this study, it was revealed that human health risks brought about by urbanization. Therefore, finally, our research highlights the need for improved urban planning and hygiene regimes that better prepare disease response mechanisms and governance among the urban population. Particular attention should be placed on the most vulnerable low to middle income country urban residents to effectively contain infectious disease outbreaks in densely populated urban regions. So, and we conclude our presentation here. We hope that you gathered some insights relating to reshaping the post-COVID world in the context of health, inequality, and tourism. So now we would like to answer your questions.
Thank you so very much for the thoughtful presentation. It was really insightful to know that how the world is reshaping itself. There are certain conclusions that I would like to draw, and then I would be forwarding the questions that I've received so far. The conclusions that I could draw from the presentations you have shared is that it seems that outgrowing the COVID crisis more promising for the relatively high developed economies than the densely populated countries or the least developing countries or the middle income countries, which basically alarms the situation that how are they going to handle the situation where following the SOPs of COVID-19 is an absolute luxury. Like in the part of world I live in, which is Pakistan and India. So like here, you might have seen the upsurge in the cases, and then the health crisis that were followed by, and then the economic crisis that is being followed by. So following the SOPs and then the government going for the strict lockdown is not really a possibility for my part of the world, which is basically again it again highlight the importance of how important it is for us to integrate internationally so that we can all get out of this pandemic globally. So the questions that I would now like to put forward is um, yeah. So the first question that one of my students asked of managerial economics and policy is that what do you suggest that how the developed economies or the developing economies should get out of this pandemic? because your presentation basically talks about that how we can, lead the developed economies to get out of, or pave their way out of this. But what are your suggestions for the developing economies? Or should I be telling all the questions once or one by one? One by one. Okay, fine. You can answer this and then I'll get you another question.
I can actually take this question. Actually, it's an interesting question that you raised. And let me sort of start out by saying it's not just the developing economies that are now facing the problem of inequality. It is I showed you the slide about the problem in the United States. And even now, as I'm speaking to you, I'm in Sydney right now, and we are in a lockdown, and we are going through a case outbreak that started in the middle of June, and it is not coming down. The reason it's not coming down is because towards the March of this year, the measures that Australian government had put in last year, had been revoked. So last year, the policy response was very guided to helping the poorer section, as I mentioned, giving the unemployment benefits and giving the wage subsidies, which are very targeted towards the poorer section of the population. And that's what we are seeing now is because those sort of social welfare nets had been removed, the compliance, even in developed country like Australia, has gone down, because for the poorer section, if you don't have the means or the social safety network to earn your daily living, it is very hard to control the outbreak. So I think the policy implication, even for developing countries, is that you have to be very mindful of the economic fact and the reality of the people who are getting the infection and their economic necessity to go out to work, which doesn't allow them to follow the public health directions. And therefore, any policy that will eventually work to get them out of it has to be directed towards those poorer sections of society. We have seen it in United States. The poorer sections, the African American sections, are the ones who had the biggest compliance problem, and that is kind of the policy implication that we can glean out of it. I'll stop here.
Thank you. I'll just take another question from Dr. Rosina.
Can you hear me? Am I audible to you?
Dr. Rosina, you are.
Okay, thank you so much. Thank you very much for very thought-provoking sessions and presentations. My questions, I would like to ask two questions. Number one is that when I heard the inequality and health outcomes, so I was thinking about that when we are talking about inequality, so we can see in USA, different states have inequality. If we can go for the another world, developed countries, we can see Aboriginal and those people who are living over there, there is another inequality. So it's not only related to the income generation. I mean, there are so many kinds of inequality which are based on social context. You can see urban and rural, which you already talked about. So these kinds of inequality, then you can find out gender inequality. So there are so many inequalities over there. So how you would like to address this thing when we are talking about inequalities and poor and rich when we are talking about, yesterday I was talking to my friend in France, Debugs. Nobody was, all were rich, very good people. They were due to the Sunday, day before yesterday, day or Sunday, they were all out and they were not wearing masks. There was no social distance, nothing was there. Even in USA, school teachers are not wearing masks. Children are not wearing masks. If we are ready to send our children to school, we are aware about why to wear masks and how to follow SOPs. If others are not following that thing, so you can see peer pressure is also coming over there. So how would you like to address these issues? Okay, another thing, you were talking about the SARS flu and other things. So in UK, Greece, Europe, every winter they are facing this issue related to the flu, and mortality rate is high during that time period, especially in the winter time period. Even in heat wave in Canada, you can see mortality rate over there. So how you can differentiate mortality rate because of the COVID, because of the flu, which every year happening in the Europe side. So how would you like to address this issue? So I think all these things, even in, you can see in Canada, in Alberta, one person sued that there is no COVID, there is only simple flu. So court give their verdict that nobody can wear mask and it's a simple flu, etc. So these things are happening across the world. How we can go for that? Would you like to address this issue as well? Thank you so much.
Thank you, Dr. Rosina. Over to you.
All right, I'll try to talk about a little bit about other types of inequalities. So I think in the economics literature, the pathways about how inequality impacts health are clearer for human capital inequality and income inequality. Other types of inequalities, such as gender, while those aspects have been looked at and have been discussed, the pathways are not so clear in the literature how that inequality, so biases are different and inequalities are different. So how those inequalities impact health related things are not so clearly identified in the literature. And I think we're also constrained by the amount of data we have in terms of how we can incorporate that. Would Debajyoti, would you like to add something more to that?
Mention one small thing that in the data, when we look at, say, gender inequality, we typically find that developed countries have greater amount of gender equality compared to underdeveloped nations. And those variables tend to be very correlated with some of the things that we have included in our study, like per capita income. And so, while it might be interesting, we didn't look at gender inequality, so I should not be saying something that I've not done. So it will be interesting to look at it, but my gut feeling would be that because it's very highly correlated with other development indicators that we have already included, like political freedom and per capita income, it's probably already being picked up by those variables. But again, I haven't looked at it. We haven't looked at it, and it's certainly something that is worth investigating. If we can find that countries with less gender inequality are able to cope with this better after controlling for all other factors, then it would be an interesting result.
Yeah, and the other question on the flu and other diseases, and how you differentiate the mortality and cases between those diseases and COVID-19 is quite interesting, actually. Like, even if you forget completely about the infectious diseases, even accidents or diabetes and heart diseases, I think the mortality rate of all those diseases is not something we should ignore and just focus on infectious diseases for that matter. But the problem with infectious diseases or pandemics that we are talking about, like, for example, COVID or SARS and swine flu or even Ebola, that sort of things, is that those are emerging, like suddenly it appears and then it goes throughout the world, and WHO identifies that as a pandemic, and then you have to either come up with a new vaccine or some particular medicine, and then you have to control it in such a way, and it is going globally. But flu and other things, like, let's look at flu. That's what you suggested. And in my understanding, most of the countries uh, have been used to live with that flu. Every year, there is some sort of vaccination happening. Whether people take it or not, it's a different thing. Whether people die or not, it's a different thing. But every year, there is this vaccination program, and it's been developing every year with new to face the new developments of that virus. But SARS and COVID-19 swine flu are slightly different. It's at a global level, and it takes time to develop certain vaccination. And with the globalization, like travel and other sort of things, local events goes global. Like, but flus, we haven't seen normal winter flus. We haven't seen it. It is happening at that scale. So I think that's the reason that these pandemics are of greater concern than annual flu that is happening at due to weather changes.
Thank you for answering that question. So I would be taking the last question because I've already taken 10 more minutes as promised. So the last question here is that I'm so thankful for you for waiting for that. But the last question is that it's more of a comment than a question. But again, the initial distribution of the opportunities is really a matter of relevance. Like if the opportunities are already inequitable, then pandemic like COVID would further widen the inequalities that are there. So how long do you expect these social safety benefits that are being provided by different governments to last? Like how long do you expect them to last? Like we cannot really expect the governments to be supporting these benefits, the social safety nets for the unmarginalized or the marginalized sector of the society.
So that's actually a billion-dollar question. I'm not sure whether I'm equipped to answer it, but at least as far as the policy settings are right now there, most of the economists are saying that right now, because the interest rates all over the world are so low, if at all a government can err, they should err towards giving err towards more borrowing and not following, say, a policy of reducing their budget deficits as much as possible. So, of course, a lot of the things are very fluid. When, say, for instance, you asked us to present at a university, Australia was going through a phase where we thought that we had this under control, but now again, almost 60% of our population is in lockdown. And it seems that many of the things that had worked earlier are no longer working. And again, policymakers and economists are again trying to figure things out. So I cannot say that I have an answer, but my gut feeling is that the only way out of the whole thing is to get as much of you get to more vaccinations. That seems to be the thing that has that sounds most promising. But again, it's just my own view. I may be very I may not be the most qualified person to comment on how far the governments can keep on borrowing. But the policy settings are there that they can borrow because interest rates are low.
Thank you so very much, but the questions are floating, but I would just limit it to here. I would be forwarding the questions to you on email. If you would like to respond, I would individually respond to the participants here as I have their information. So I would like to thank the participants for patiently listening to the respected panelist, Ms. Sabi, the Innovative Research University and Mr. Grish from Charles Darwin University, and of course the respected panelist, Dr. Maneka, Dr. Debajyoti, and Dr. Bhanu. I hope that such collaborations would be happening in the future too. Thank you so very much for your time and for the thoughtful information. I will definitely get back to you, and I hope that you would stay in touch with us as well. Thank you so very much. Hope to see you in some time other time. Thank you. Allah Hafiz.
Thank you very much.
Take care. Bye-bye. Bye.